All right, next speaker, are you guys ready? It's been a good morning so far. It is my pleasure to introduce her. Dr. Nzinga Harrison is a well-respected physician and educator, the chief medical officer and co-founder of Eleanor Health in North Carolina. Dr. Harrison earned her bachelor's degree in biology with Spanish and chemistry minors at Howard University, completed medical school at the University of Pennsylvania School of Medicine, and general psychiatry residency at Emory University. She is board certified in both adult general psychiatry and addiction medicine, and has spent her career treating individuals with serious, persistent mental illness and addictive diseases. She is married to a day trader, has 2 sons, ages 12 and 13, and her parents are joining us today. Please help me welcome Dr. Nzinga Harrison.
Thank you so much, Brooke. To start out, I wanted to just thank Brooke for sharing so freely Emma Noel with us. I thought that was beautiful. The number of hearts you can touch by being open with your pains and sorrows and triumphs is infinite. I want to thank Dr. Chris Box and her team for inviting me to come home. So Indianapolis, Indiana, born and raised. North Central, NCHS, anyone? Okay. The rest of the high school's governor and I were backstage laughing because he went to Pike. So he was like, don't hold out. I was like, you know, once you get old enough, then we can let these rivalries drop. But thank you to Chris Box and her team, Dr. Chris Box, for bringing me. And then, as Brooke mentioned, my parents, so my dad and stepmom, Shalmer, in the house to come see their little girl on a stage in front of a lot of people doing things. So I did not plan my outfit appropriately this morning, had nowhere for a mic pack to go. So I like to walk the stage, and so I'll pretend to be Beyonce a couple of times with my hand mic so I can get on this side. I promise not to try to sing or you guys will be like, go home, effective immediately. So what we're going to talk about this morning is connecting communities, mental health and substance use disorders in mothers. My first soapbox that I'll start out with is that this distinction between mental health disorders and substance use disorders is a false distinction. Substance use disorders are psychiatric illnesses, are mental health disorders, all arising in the brain. And whenever I start a talk, I always say, does anybody want to fight me about that? Because I'm willing to fight. If necessary, I have on like my sharp heels and we can go. I think the less we separate substance use disorders and mental health disorders, the more we can become compassionate and the more we can become educated about the brain chemistry that underlies those. We'll go through that today. And then my second soapbox is that mental health and substance use disorders are physical health disorders. So the distinction from mental health and substance use disorders and physical health disorders are all rooted in stigma. And so what I would compel this crowd to do is to just start breaking down those stigma barriers in your mind so we can just start thinking about the entire person, right? The body cannot walk around without the brain, and the brain cannot walk around without the body. So to consider them separately is not grounded in science, is not grounded in real life, so we're just gonna try to put them all together. So I always start out with this quote, and by always I mean for the last 2 months, because that's when the guy wrote the article. This is by Matt Bell, who is in recovery himself, wrote this beautiful op-ed. I forget what the venue was. But the entire premise of the article was that addiction is the epitome of disconnection. And so the theme that they asked me to go through for this particular talk is connecting communities and how through mental health and substance use disorders, the policies, the programs we put in place, how we can affect infant mortality. And so I want to use this as the foundation of the talk this morning, that addiction to me is the epitome of disconnection. So in theory, recovery means being connected again. When we think about those connections, those are rippling out individuals, families, communities, the country, the laws that we make, and then we'll get later, they ask for a framework for how we can be thinking about policies, and I'm going to give what I think is probably a little bit of a different framework than you're used to, but also thinking about this concept of health in all policies and how that's connected. So if you're in education, you're making health policies. If you're in housing, you're making health policies. If you're in cardiology, you're making mental health and substance use disorder policies and recognizing how we're not dealing in concentric circles, but instead in a web that's constantly affecting the other parts of the people that we're taking care of. And so this is what I would like to do today. These are our learning objectives. And you see I have my little graphic there on the side, individuals. So I just recently turned 43 and my vision is going. I just tried to look at this and I was like, I can't even read. I can't even read what that graphic says. So read it for yourselves. Anyway, upon completion, what we hope to do this morning, this is where I take my little walk, and I'm also super clumsy, so I'll try not to give you any viral videos today. I want to go through the neurobiology and physiology of substance use disorders and other mental health disorders. And so I language that way intentionally to drive home this idea that substance use disorders are mental health disorders. So it doesn't say substance use disorders and mental health disorders because that would make it seem separate. So substance use disorders and other mental health disorders, including substance use disorders and mental health disorders. We tend to think about the mother and the baby as a singular instance. And I really want us to broaden our thinking to recognize the generational effects that the experiences of mothers are having. It's like this chicken egg, right? You have which comes first, and the answer is yes. You have the chicken, the egg, and then the chicken and the egg, and then the chicken and the egg. And so when we're thinking about the policies that we're making, the advocacy that we're doing, the services that we're providing, the experiences that people are having, we have to recognize that these actually have generational consequences. It's not just decreasing the infant mortality risk from this year to next year, which we want to do. It's even taking that longer arc of a view with how is this affecting the next generation? How is this affecting the generation after that? And then finally, we'll talk about a biopsychosocial, cultural, political. I think every time I give a talk, I add another set of syllables on here. So it starts out biopsychosocial, and then I was like, I need to add culture in there. Because biopsychosocial is not mine. That's just a concept that exists in health. We'll go through it. But I used to say biopsychosocial cultural, and then I was like, oh, but then I had to have political too. And I was like, biopsychosocial, cultural, political. And then I was like, supercalifragilisticexpialidocious, whatever, right? We'll go through. This is the framework that I want us to start thinking about how we're thinking about policies. And I think it'll be a little bit different, and then you guys can tell me what you think about it when we get later. So here we go. Here is a basic foundation for what we're going to talk about today. Mental health and substance use disorders and other mental health disorders, these are lazy abbreviations, are chronic medical conditions. So just honestly, show of hands, and I want you to be honest, like there is no judgment here, although yes, there is. Is there anyone in the crowd that doesn't fully accept that substance use disorders and mental health disorders are chronic medical conditions? All right, so either this is a totally friendly crowd or else you knew that was a hostile question. That's fine. It's fine. One of the ways we think about chronic medical conditions, and the reason I always go through the biology and the neurobiology is because I think that allows us, when we're looking at those parts of the illness that a person is not choosing, right? So it's very difficult for us as human beings to see behaviors, even though they're a symptom of illness. It's very difficult for us to separate behaviors from the personality and the choices of a person. And so it's easier for us at times to see genetic risk or the biological components of an illness. That can sometimes make it more easy for us to get and fully commit to this concept that substance use disorders are chronic medical conditions. And so part of the purpose of this slide really is to break down the implicit beliefs that each of us has around substance use disorders. There's no way that every single person in this audience doesn't have it because we start getting ingrained with them from when we're very, very, very little. So just unintentionally, myself included, have these, which is like addiction is a choice, right? We're starting to move away from the idea that addiction is a character flaw, but just recently. Right? I was in a room yesterday speaking at a conference of health insurance companies from around the country about Medicaid transformation. And this was a totally 100% friendly crowd. And still, the very last slide of that day, talking about increasing access to treatment, was if the person's really committed. Bleh, barf. Right? Barf. So tell me, when you hear us talk about a person with cancer, which is a chronic relapsing remitting illness, and a person has been in remission, and then they have a recurrence of cancer, and you say that recurrence was because they didn't want their cancer to stay in remission. Literally, somebody would dig a hole for you and throw you in it. Right? And so I want us to get, and so if you say that about substance use disorders, I'm gonna dig a hole for you and throw you in it. Literally, I want us to get to the place where we have the same level of understanding about the biology of a chronic relapsing remitting illness, that is substance use disorder or other mental health disorders, and the same compassion for that. And I recognize that this is a tall ask because it's difficult when we have a mother who's using and we think about the baby in the womb, right? That is automatically gonna engender feelings in us. But remember, the overwhelming majority of mothers want to stop using when they're pregnant, but there's an underlying illness that's driving that. Just like sometimes just wanting it is not enough. Just like I would say, the majority of people who get married want to stay married, but sometimes just want it, it's just not enough, right? Sometimes it's more. So with substance use disorders, you have the underlying illness driving. Then if we can start to separate the illness from the person, even though the illness is manifest in behaviors, if we can start to separate that, then we can start thinking our way through advocacy and policies and community interventions and other interventions that will actually affect the infant mortality rate. And so when we look at the heritability coefficient, this is a concept in medicine that says, what percentage of an illness is just in your DNA? You're just born with it, you got it from your mama, as the song says, right? That's the heritability coefficient. It measures from 0 to 1. So the closer it is to 1, the more inherited is your risk for developing that illness. And look at this. We look at substance use disorders, our heritability coefficient, this is the range of studies from 34% to 61%. So as much as 61% of an individual's risk for developing a substance use disorder is coded in their DNA, born with it. Not anything they did, not any part of their fault at all, born with it, right? And so when we think about substance use disorders as a choice or as a character flaw, look how it stacks up to the rest of the chronic medical conditions that we don't question to be chronic medical conditions. Asthma, higher heritability coefficient, but close, 70 to 61 if we look at the high end. Diabetes type 1, like do you say your blood sugar is not low because you don't want it to be? Diabetes has a lot of behavioral inputs, but you don't get diabetes because you want diabetes, right? You get diabetes because of some confluence of biological, psychological, and social factors. The biological component is about 55% just born with it in your DNA. Lower than addiction. Looking at hypertension, about 50% lower than addiction. And so while it's easy for us to conceptualize that diabetes, somehow your biology just puts you at risk for that. Hypertension, your biology just puts you at risk for that. It's harder for us to recognize for addictive disorders, your biology just puts you at risk for that, but here are the numbers, right? And the other thing we run into is like, but treatment for addiction doesn't work. And so there's this feeling of hopelessness and helplessness that's developed, like we pour resources in and still people go back to using. And I want you really to start working on your language, which is like, still people go back to using the less pejorative, non-stigmatizing ways to say the illness relapsed. Not the person relapsed, right? Take it back to cancer. So when you're talking about substance use disorders, and this is going back to the connectedness because we unintentionally marginalize, especially mothers with mental health and substance use disorders. because we think they should be making better choices. And so that engenders emotions and thoughts in us. And even if they're not rising to the conscious surface, like, I'm a psychiatrist, right? So like we're on the couch right now. Even if those feelings and thoughts are not rising completely to consciousness, it affects the way that we're interacting with people. It affects the policies that we're making. It affects how much we're willing to bend over backwards to help someone. And so when we're using our language right, if we can bring it out of the person relapsed, it's the illness that relapsed. Think about the person with cancer. You don't say she relapsed, you say the breast cancer relapsed, right? And it's because we blame the cancer for the symptoms that she's having. We don't blame her. So I want us to get to the same place with substance use disorders and other mental health disorders where we're blaming the illness for what this mother is going through or this mother-to-be, not blaming the mother for her symptoms. So this question, does treatment actually work? The answer is it works just as good as treatment for any other chronic medical condition, right? I mean, we have a long way to go for the treatment of chronic medical conditions. This is one of my favorite studies. Sorry, the reference is down there in black, but this is a fundamental study in addiction medicine, which is by McClellan back in 2000. So if you look at after 1 year for these different chronic medical illness, what percentage of patients were following recommendations for medication and lifestyle interventions, okay? Because the idea is like, oh, people with addiction just gonna relapse, they're gonna go back to using because they don't follow treatment recommendations. I hate to break it to you, that's just like humans. Humans we just don't do what we're supposed to do. It's like actually part of being human, right? So we look at addiction, 40 to 60% after a year of following recommendations. Relapse rate, 40 to 60%. So we start thinking about root cause, then we say, maybe we could get that relapse rate to be lower if we could make recommendations that people could actually follow. So I forgot when I opened up, I forgot to thank Governor Holcomb, one, for being here, two, because he has put his money where his mouth is on this issue, right? So a lot of times we hear mouth and we don't see money, but like money is where the mouth is, so that's awesome. But three, because when he was talking about ROI, return on investment, he never mentioned money. He talked about people, right? And so when we think about these follows treatment recommendations, a lot of times we're making treatment recommendations that people just literally can't follow. Take this medication, I don't have money to buy it. Come to treatment every day, I don't have a way to get there. Don't use, I live in a rooming house where everybody uses. Don't drink alcohol, I go in the grocery store and I can't not walk by the beer aisle. I can't watch TV. I can't walk down the street without seeing a billboard. I can't go on Facebook without seeing a meme that says it's 5 o'clock somewhere. Right? Like, are we asking people to do things that are literally, given the circumstances of their life, not possible to do? If we look at root cause, then we need to try to be making recommendations that people can actually follow. Look at asthma. Less than 40% are following medication recommendations at a year. Less than 30% are following lifestyle recommendations. That's worse than addiction. Diabetes, less than 60% are following medications, less than 30% lifestyle. Look at the relapse rates. Comparable, right? So addiction is performing like all of the other chronic medical conditions we have. And that's really not because people don't want to get well. That's because we have systems that are disconnected or not supporting people in getting well. This is the same information depicted in a different way. I put on the right-hand side of there the criteria for substance use disorders. So there are 11. The other thing is we have to get away from this idea that using once equals a relapse, because that makes us kick people out and disconnect people. I have a guy, actually I just saw him in clinic 2 days ago, came to me from another treatment provider, heroin use disorder for the last 6 years, had 2 years in the past on buprenorphine where he was in remission, was not using, thought he had it in the bag, stopped his buprenorphine, relapsed to heroin, was using heroin until 64 days ago when he went in a program. He hasn't been using for 64 days, but this program required him to come every single day to get buprenorphine and be in group for 3 hours. He works 13 hours a day. So he would go to work 3 a.m. to 2 p.m., drive to the treatment center, sleep in the parking lot until group started at 8 a.m., but he could only get himself to do that 2 or 3 days per week. They kicked him out of treatment for non-compliance, for not coming to group. They tapered his buprenorphine over 3 days, and on the 6th day, he used heroin. Is that on him? That's on us. Look at my dad's my amen corner. That's on us, right? Thanks, Dad. So this idea, substance use disorder, using once. Now, he used once on Saturday. I'm seeing him on Tuesday. Obviously, I get a Suboxone back up. I'm like, okay, we need you to sleep at night. You don't have to come to the clinic every day. Like, we can make your appointment at noon so you can sleep from 3 to, like, work with the man, right? Try to make it happen. But relapse is when you meet more of these criteria, at least 2. So just using once, think diabetes. Your diabetes has been controlled, and you get 1 high blood sugar. Do we say you relapsed because you don't want your diabetes to be in control, so we're withdrawing treatment? Is that blood sugar gonna get better? No, right? It makes no sense. And when we're thinking about mothers with substance use disorder, honestly, just yesterday I was talking to a person, and people tell me things. And then then I say, what do you do? And I'm like, psychiatrist. Then they tell me all the things, right? I hadn't even told this person I was a psychiatrist, but he was excited because he's about to finalize adoption for his grandniece, who is an infant. And I was like, oh, how did you get your grandniece? I also be asking people their business. So then they tell me their business. His niece, who's 29 years old, pregnant, substance use disorder, baby was born, she was positive for marijuana, baby was positive for marijuana. He says they gave her 45 days to get her act together, but she couldn't, so the baby's in DCS. I seriously just wanted to break something. 45 days to get your act together completely undermines that this woman has a chronic medical illness that needs connection, right? Completely undermined it, but these are the types of policies that we put in place that makes things worse. So, okay, treatment approach used in all areas of medicine. Let me stop preaching and just go through these slides. Biopsychosocial concept of health, right? The biopsychosocial model is a concept used in all areas of medicine. It says that illnesses develop for biological reasons, psychological reasons, social reasons, and then I added on cultural and political reasons. Those same buckets either make an illness worse or make an illness better. And so what we need to hold ourselves to is enacting policies and programs and advocacy programs that are thinking about each one of these buckets and how it is making things better. Does this match the biology of the disease? Does this make the psychology better or worse? What are the social, cultural, political inputs? And am I addressing those with this policy? And so when we look at what falls under each one of these buckets, biological splits into 2. We'll go in on the next slide, genetic and acquired. Genetic you're born with, acquired you get at some point along the way in your life. Psychological is life experiences. Our life experiences as a child inform our view of the world, and we lay everything into that framework as adults to reinforce what we came to believe as a result of our childhood experiences. Social is ongoing stressors, and then cultural political goes with ongoing stressors, but culturally being connected, having life meaning. Politically, stigma, racism, discrimination, marginalization, criminalization, oppression, all of these affect health. And if we're not proactively thinking about every single one of these buckets as we're creating our framework for policies for mothers with substance use disorder and maternal health, we're doing not a good job. So every policy will have unintended consequences. That's why they're called unintended. Like, I didn't even think about it, and now I see it, and now I'm gonna try to do something about it. But if unintended consequences come in one of these buckets because we didn't consider it when we were formulating that policy, then I don't let you call that unintended. We have to take the responsibility to think through all of these. as we're thinking about programs and policies and advocacy, because as much as possible, we want to predict unintended consequences so that we can avoid them. Some we won't be able to, but just not thinking about it, we can't accept that from ourselves. So we already talked about the genetics of substance use disorders. Up to 60% is in your DNA. That means we have 40% that we can work with, that we should hold ourselves responsible for working with. These are examples. You're born with it. We know that, for example, depression runs in your DNA, okay? Example, though, the brain is responsible for depressive symptoms. So if you have a stroke in the right part of your brain, your risk for depression goes up because the brain is the organ from which depression develops. So let's talk a little bit about neurobiology, and then we'll cruise through the rest once we lay this foundation. We have two main systems in the brain that are forming our thoughts and our emotions and our behaviors. And so the first is the limbic system, and it's abnormalities in these symptoms that lead to mental health disorders, including substance use disorders. So if you look at this little brain right here, where we start with the olfactory bulb and then go hypothalamus, amygdala, and up, I'm going to point out a couple of structures to you. One, olfactory bulb, that's your sense of smell. That's the strongest evocateur of memory, right? So if you have a person who's in recovery and they're walking down the street and they smell something that smells like cocaine cooking, that will automatically trigger cravings for them, completely automatically outside of their control. Same way you can be walking down the street right now and you'll be like, why am I thinking of grandma? And it's because you walked by a bakery that was baking apple pie. Automatic, no control over it, right? And so the olfactory bulb, the hypothalamus, and the thalamus are actually the translators between the brain and the body. So the same chemicals run through your brain and your body. But I say it's kind of like Spanish and Portuguese, like close but not the same, right? So if the body speaks Spanish, then the hypothalamus translates that into Portuguese, and the brain speaks Portuguese, then the thalamus translates that. But it's the reason why you say you get butterflies in your stomach when you're anxious, because the brain sends a message through your whole body and all of your organs respond without your control, right? You ever sometimes, like it'll happen to me, I'll be like, I feel anxious about something. I have no idea what it is, but I can feel it in my stomach. I can feel it in my heart. I can feel it that I'm tense, and my brain is interpreting those physical sensations, right? The issue is that, guess what low blood sugar feels like? Anxiety, alcohol withdrawal, heroin withdrawal. They all feel exactly the same. So when I have a mother who is pregnant, actually, the little baby flutter kicking feels like anxiety, right? If I have a mother who's in recovery from alcohol use, so her brain doesn't say, oh, that's the baby kicking very early on. The brain says, we're anxious. We know what fixes anxiety, alcohol, right? Constant risk. And so connecting women to the support systems that can help them be managing that, right? The frontal lobe is the other one that I want to point out. Oh, I was pointing at myself. Oh, okay. What is happening? Oh, I said I wasn't going to sing, but then I did. Here we go. Frontal lobe, prefrontal cortex. That's where your thinking and your decision-making is, okay? That's where everything happens behind the scenes. The time that it takes you to react to a visual stimulus or any stimulus, touch, visual, hearing, smell, is about 500 milliseconds. Your brain takes that stimulus, sends it throughout your body reacts. It takes about 1,500 milliseconds for that stimulus to come to consciousness. So a full 1,000 milliseconds, which the easier way to say that is just like 1 second. That's math. I tell you, you see, your teachers told you would need math. There it is, right? 1 second, you're totally at the mercy before any of that comes to consciousness. When it gets to the prefrontal cortex, your prefrontal cortex is your CEO. It says, oh, I've taken all of this information. This is what I've decided it means. This is what you should do about it. So when we get to the motivation pathway, which used to be called the reward pathway, and we've changed that now because we know this is the pathway underlying substance use disorders, and the reward pathway is actually stigmatizing. It's like people are using for a reward. When you look evolutionarily, the purpose of the motivation pathway or the reward pathway, was staying alive. Okay, propagating the species like survival is the purpose of the motivation pathway. It's a 3-neuron pathway, super simple. Starts in the deep brain. The deep brain is involuntary. You have no control over it, period, with a T, okay? No control over it. So that first neuron, right there in the ventral tegmental area, I know y'all don't care about that unless you're just nerds like me. Ventral tegmental area feeds forward to the nucleus accumbens. This is dopamine, and then feeds that forward to the prefrontal cortex. The message of dopamine is you need it to survive, period. So the natural determinants of dopamine are food, water, sex, nurturing. Can you live without food? No. Can you live without water? No. Can you live without nurturing? No. Can you live without sex? Maybe. But can the human species live without somebody having sex? No. Okay? So these are the natural determinants for individual and species survival. The problem is synthetic drugs come along, so it's like in the brain, the size of the signal matters. So the size of a dopamine signal for foods like a light bulb, like you're starving. I always tell this story, you're like in the jungle, and you got your loincloth or your coconuts, depending, right? Starving, you like see a gazelle, and the ventral tegmental area goes ping. We need to eat that to survive. Sends it forward to the nucleus accumbens. You don't even know this is going on. Finally lands on the prefrontal cortex. Rises to your consciousness. The prefrontal cortex says, make a plan to kill that gazelle and eat it. You eat the gazelle. Dopamine. Bing, light bulb. Make a plan to make sure we never go without gazelle meat because it'll keep us alive. That's the way it works, okay? Here comes cocaine. Cocaine signal, if food is a light bulb, cocaine is the brightness of the sun. Literally in the lab, we showed the magnitude. It's 10 to the 9th dopamine signal, okay? So just purely in the brain, the way that the brain functions, what's more important, cocaine or food? Everyone? Cocaine. Is that because I'm a bad person and I choose cocaine over food? That's because the dopamine signal is the brightness of the sun. What's more important? Y'all shout it out for me. Cocaine or water? Cocaine or sex? Nobody pull that quote. That's like the kind of clip that goes viral, right? It's like she's up there yelling about cocaine and sex. Okay? Here's one for you. Cocaine or family? According to the dopamine signal, right? Not because that person is just choosing cocaine over their family, but because the dopamine signal for cocaine says you need this more to survive. So, you know, all of these AA slogans are actually based in biology. When they say your brain has been hijacked, this is what they're talking about, the dopamine signal. So when they gave that mother 45 days to get herself together when her brain had been hijacked, is that fair? And then when they take the baby, does that help? Right? We have to think of a different way. This I always put in here because when they say recovery is a lifelong journey, recovery is a lifelong journey. This study is done in the UK. They had people who were in recovery from cocaine for 20 years. They put them in the fMRI scanner, which shows you which part of the brain is working. You ask people to do things, and you can see which part of the brain is working by how much sugar it's using. They show them nature video, deer, rabbits, fox, whatever, like people are falling asleep, like this is boring. They show them video of people doing lines. Now these people were in recovery 20 years, and they had to stop the study early because the amygdala went out of control. Dopamine pathway was like, VTA, nucleus accumbens, prefrontal cortex, get some cocaine, we need it to survive. Cravings went off the chart, and they stopped this study early for safety. 20 years these people are in recovery. Is it because they wanted to go back to drugs and ruin all of the stability they had garnered over the last 20 years? Anybody want to say yes? Y'all see me getting hot up here. Hot and bothered. Not like that. Get your minds out of the gutter. Psychological. That was the biological piece, right? Psychological. Childhood experiences matter. I want to skip straight to trauma and ACEs. Trauma relationship with substance use disorders is bidirectional. We know the rate of trauma in this country especially, is super high, especially for our marginalized, lower income, rural mothers of color. The more of those you have, just add up the ACEs score. This concept of ACEs is adverse childhood experiences. It's basically a scale of 10 different domains that has been shown the higher your score is, you get 1 point for each one of these that you experienced as a child. Your risk, you can see the bars. IV drug use, exponential. Smoking, exponential. Alcoholism, exponential. This is for all so many chronic medical conditions. The same pattern is true for asthma, diabetes, hypertension, obesity, cholesterol, premature death. I could just keep going, right? Every single one of those. The line has not been drawn directly to infant mortality from ACEs, but the line has been drawn directly to low birth weight and premature birth. And then through all of the rest of those chronic medical conditions, these that I have on the slide included, are drawing an indirect line to infant mortality. And so this means we should be building systems and supporting communities to help raise kids that get as close to zero as possible on this. Score yourself. The people that I take care of have an average score 7, 8, 9 on ACEs. That's our responsibility, right? So that ACEs, that's the 40% we had to work with for these folks who have generational substance use disorders and already have 60% genetic burden. We're failing on our 40%. My kids right now have ACEs score of 0. I think we should have parenting classes that introduce ACEs and try to support people to get as many kids through childhood with 0 as possible. It's an idea. I showed this to my husband. I was like, we need to keep these kids' scores 0. So you need to not be acting foolish up in here. Epigenetics, generational effects, okay? Our stressors actually change our DNA. It's a process called methylation. I don't know, anybody? Organic chemistry, CH3, methyl group, right? Oh, she raised her hand. Hey, chemistry. Methyl group, CH3. Adding it on the DNA changes the way the molecule folds, blah, blah, blah. The point is, passed on to the next generation. So if I had 40% genetic risk, and then my stressors, not enough food, food insecurity, housing insecurity, job insecurity, family insecurity, disconnected, substance use disorder, in jail, domestic abuse, raped when I was a child, stress, methylation. My gametes, now I pass on to my next generation, have 60% genetic risk. And the chances that my kids are born into the same environment that I came out of, right? We gotta do better. Social, cultural, political. I've put this through all the way. I've said the words racism, oppression, discrimination, marginalization. If you are not saying those words to yourselves, you are intentionally remaining blind. I don't see color. It's not possible unless you don't see. Do you see? Because if you see, they'll be like, what race was Dr. Harrison? You'd be like, I don't know, I don't see color. So the goal is intervene in all of these areas, biopsychosocial, cultural, political. If we want to be making a difference, then we need to start with our value set. I love this quote by Monique Tula. She's the executive director of the Harm Reduction Coalition. She says, harm reduction is the practice of unconditional love for people who use drugs. So what makes us revoke unconditional love? These are the ACEs. If you look at people who score even 1 on this, aren't these the people that need the most love and connectedness from us? But aren't these the people who are getting the least? I can tell by your silence that you're with me. So the framework, and I got a minute and a half to go because you know they put the timer on us right now. And they're like, you don't got to go home, but you got to get off this stage, right? Framework for connectedness, health in all policies. Think about health. period. Think about individuals, families, communities. So if you're thinking about a new program, you're thinking about advocating for something, you're thinking about writing a policy, you're thinking about writing a rule, thinking about writing a regulation, thinking about talking to an individual, ask yourself, who does this help? Force yourself to ask the question, who does this hurt? An article just came out November 19th that showed that states that have punitive criminalizing policies for mothers who use drugs during pregnancy have higher rates of neonatal abstinence syndrome. Those people will tell you we made it a crime to use drugs during pregnancy to protect the fetus. Didn't work. Who does this help? Who does it hurt? Does this policy improve the biology of the illness? Postpartum depression. Depression is considered postpartum onset if it happens within 1 year of pregnancy or delivery. Does Medicaid cover pregnant women through 1 year in this state? Okay, something to think about. I'm just saying, easier said than done. Okay, clap. I'll take the claps for extended Medicaid. Psychology, does this policy mitigate the psychological causes of the illness or exacerbate them? Social, cultural, politically, have we intentionally considered the marginalized, discriminated, oppressed, and built in protections for them? And ACEs, does this policy reduce ACEs? If you send that mother to jail, you just gave that infant an ACE score. And on that dramatic pause, this is how you can get to me. And the most important thing I ever did in my life is right here. And that's it. Thank you.